This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, I'm Dr. Deepak Megur and we have an interesting case today. He is a 65-year-old gentleman who has a traumatic cataract which is long-standing, and he doesn't remember when he had trauma, maybe about 15-20 years back. The cataract, what we're seeing, is extremely dense, hypermature, and the most important thing is I'm able to see a bare area in this region. This looks like a subluxated lens, but mind you, there is no significant phacodonosis or iridodonesis, suggesting that the health of the rest of the zonules seems to be alright. Now, how do we plan surgery in this case? The first I have to decide between phaco and manual small incision cataract surgery, and looking at the density of the cataract and the overall health of the anterior capsule, I'm not certain that phacoemulsification is going to be very safe in this patient. So I have made a conscious decision to perform manual SICS in this patient. Now, if I'm doing manual SICS, how do I plan the surgery in this patient? So let me take you through the step-by-step points which I have thought in my head in order to plan the surgery in this patient. Number 1, I would be doing a scleral tunnel incision, which would be measuring about 7 mm, looking at the density of the nucleus. Now, where do I place the incision? In this case, I have decided to place it in the superior quadrant. Now, how do I stain the capsule? Because in this case, I want to ensure that the dye does not percolate posteriorly. My idea is the red glow shouldn't be hampered by the dye which escapes into the burger space. When I'm staining the capsule, I want to use as little dye as possible, and preferably under a single large air bubble. Next, what should be the size of rhexis? Now, rhexis becomes a very important step in this patient simply because if rhexis is there, we can use capsular hooks if need arises, or we can put in a CTR. The rhexis has to be intact. That is the first priority. Second priority would be it has to be at least 5.5 mm or 6 mm so that I shouldn't have any difficulty in prolapsing this large and bulky nucleus. And to deal with the zonular dehiscence, I would be using a CTR of appropriate dimensions. And in the worst case scenario where I'm unable to save the bag, then I would have to resort to an iris clip lens, which I've got it ready as a standby. And to ensure that the side ports are appropriately designed for the enclavation of the iris clips, I would like to mark them beforehand itself. Needless to say, I will also be ready with all the extra instrumentation which is required for performing anterior vitrectomy. Let me begin the case. The case is being done under peribulbar anesthesia. The conjunctiva is reflected. The epithelial tissue is scraped off. I prefer to always make a posterior scleral groove which acts as a fixation groove for me, which stabilizes the globe as I make the scleral incision, which is about 1.5 mm behind the limbus, measuring approximately about 7 mm. A crescent knife is used to create a sclerocorneal tunnel. I begin usually by tunneling from the central part and then extend it laterally. I always prefer to have the inner lip, that is the corneal lip, wider than the external scleral incision so that the nucleus delivery is relatively easy. So the tunnel is done. For the side ports, I'm using the toric marker so that I get exactly the marks at 180 degrees apart. The two side ports are created. Trying to stain the capsule with very little dye, and unfortunately, I don't get a single large bubble, but this didn't go as per plan. But I'm hoping that none of the dye has escaped back behind. While irrigating the dye off, it's important to press the posterior lip down so that most of the fluid egresses out, rather than creating a pressure from the front which can direct the dye posteriorly. Dispersive OVD is placed into the anterior chamber. There are dual benefits of it. Apart from coating the endothelium, we're also using it as an barrier to prevent the vitreous from prolapsing out through this area of zonular weakness. Time to enter the anterior chamber. Using a 2.8 mm keratome, the internal lip is perforated and the wound enlarged to the appropriate size. Time to perform the rhexis. The flap is raised with a bent 26 number needle. The flap is then held with the capsulorhexis forceps and then the rhexis is being performed. At this point, I realize it is slightly smaller in the superior quadrant. So I go in with my micro scissors and give a small tangential nick to it. And then the flap is raised and the rhexis is enlarged in this quadrant itself. During capsulorhexis, I did not notice any evidence of zonular weakness in the remaining quadrant. Now it looks like a decent sized opening and it should ease the nucleus manipulation into the antechamber. I plan to do a gentle hydrodissection just to rule out any corticocapsular adhesions. During this maneuver, I was skeptical because the AC is going to shallow momentarily and I was worried whether at this stage there would be a breach of the anterior-hyaloid and the vitreous would prolapse out. Thankfully, it doesn't seem to be so. The nucleus is well and truly free from its attachments to the bag. So I'm using two Sinskey hooks to gently dial the nucleus out of the bag into the antechamber. Now the entire nucleus is in the antechamber and still the bag is intact. There's no evidence of any vitreous prolapse. Under the cover of OVD, the nucleus is expressed out using the phaco sandwich technique. The bag is well formed with OVD. The first thing which I want to do is to insert the CTR so that the weak area is stabilized first. So I'm going to thread in the planned CTR. In this case, I'm using a 12 to 14 millimeter bigger CTR. Although the axial length and the white to white were normal, I just wanted to ensure that the CTR does support the area pretty well. It's important to realize that the CTR is being threaded in a direction in such a way that the weak area is being supported first, followed by the rest of the area. By doing so, we ensure that the stretch on the weak zonules or the weak quadrant of the bag during CTR insertion is minimized. The CTR is well and truly into the bag, and now is the time to clean the bag. The bag is looking a little bit dirty because of the Elschnig pearls. Because of the long-standing nature of the cataract, we see these Elschnig pearls, and the quick way to remove this is to just keep on irrigating the posterior capsule, and the irrigation fluid itself is going to take care of all these small lens opacities. Once the bag is clean, time to put in the lens. As I put in OVD, we can see the shape of the rhexis has changed now. That is because the CTR which we have pushed in, it is stretching the bag and it is causing the rhexis to be oval. A multi-piece lens was planned originally for this eye and that is being implanted into the eye. Once the lens is in place, the OVD both in front and behind the lens is being removed out. Now, since the area of the zonular weakness is being very well supported by the CTR itself, it is not very imperative or mandatory that the haptic orientation has to be in a particular way. The OVD both in front and behind the lens is irrigated out. Before closing, I'd like to do one final check for presence of any prolapsed vitreous. Diluted triamcinolone acetate is used and there is no evidence of any vitreous prolapse. And the side ports are hydrated and that's it, the case is done. So that was it. Thank you for watching and hope you found this helpful.